Your initial thoughts when you get told you have cancer is you think you're going to die. You know, it doesn't matter. That's it. Cancer's going to kill you. You know, that's how my head worked on it. This, you know, the first thing that props up, prostate cancer. You know, 1 in 10 people die from it, and you think, holy shit, I'm one of those people. So Dr. Google comes into play. You go online and you do this and you do that and you check out absolutely everything and anything. I read some academic papers, and I formed an opinion quite quickly that all the procedures that were there in terms of, you know, the surgery and in terms of brachytherapy or hormone treatment, whatever, they all seem to have long-lasting side effects in most cases. Surgery sounded quite brutal, if to put a word onto it. I thought there would have to be something else, and during the sort of the studies and the research, I discovered this radiotherapy called SBRT.
My name's Professor Duncan McLaren. I'm a consultant clinical oncologist here in Edinburgh and specialise in genitourinary cancers. So I do radiation treatment, but also systemic drug treatment for mainly prostate cancer and bladder cancer. And in the past, I treated an awful lot of kidney cancers, but pretty much all prostate cancer these days. We've learned that setup accuracy is really important, that it has to be delivered with precision. Everybody has to be on the team, understand how to deliver this radiotherapy to the utmost. Otherwise, you can run into problems when you're delivering such big radiotherapy doses in such a small number of treatments.
So my name is Joanne. I'm Joanne Mitchell, but I'm known as Jo to everybody here. I am a therapeutic radiographer, or an RTT, working at the Edinburgh Cancer Centre. To deliver the treatment, there's motion happening all the time. You can't take away motion, no matter what you do prior to the patient coming in, no matter what information you give to the patient. If you have a living, breathing patient on the bed, you have motion.
In the early days, people didn't really take into account where the dose to the centre of the prostate was going. Okay, it was all about protecting the dose to the rectum. So when you plan radiotherapy, you're trying to spare dose to the normal tissue around the prostate. So the machines for planning, the computers would tend to push those into the middle. And what we now realise in the middle of the prostate is where the urethra runs. So we think some of the side effects that we were seeing early on, and in fact a lot of people now realising are there, was probably because people were pushing the dose into the urethra without realising it, which was normal because you're trying to spare the dose to the rectum.
SBRT has this, you know, this element of being very precise with the radiation treatment. It delivers radiation over a short period of time. So in my case, 5 days of treatment spread over 7 days, as opposed to standard treatment, which I would have had been over 13 weeks. So you have this short period of high dose radiation, but very much targeted on the cancers on the prostate. But the additional trial had this wonderful bit of technology called RayPilot. Now, for all intents and purposes, RayPilot's a guidance system. It's like a GPS system. It monitors any movement within the bowel and within the prostate area. So if there is any movement at all when you're under radiation treatment, the GPS system, the RayPilot system, stops the radiation actually being transmitted, because any movement above 2 millimeters, you could be missing a tumour, you could be targeting healthy tissue, whatever. So SBRT in its own, fantastic. With this additional benefit of the RayPilot system, it's a bit of a no-brainer.
From the RTT's perspective, using the HyperCath device, with the device now being placed as a urinary catheter, it's allowed us as RTTs, we can see the urethra as an organ at risk. That there's literature out there that does state that there's a potential correlation, a direct correlation between the dose that the urethra receives and a GU toxicity that the patients do experience. But when we've delivered our treatment using a linear accelerator and we take a cone beam CT, you can't see the urethra. So it's never been an organ it's never been a structure that we have probably had to really take into consideration. So for us as a team, as an RTT team, we're looking to see how we can match our patients to the urethra, so actually really know what dose we're delivering to the urethra that'll be matched more accurately to the plan that we've created at the beginning.
We spare the dose to the urethra, where we didn't previously because we didn't know where the urethra was. So our dose is designed to ensure that we try and push the dose towards the tumour, so we can see that with our MRI that we use as part of our planning process, and limit the dose to the rectum, but particularly keep the dose to the urethra down.
We can adapt our treatment plans, we can have plan of the day, we can look at which is the best plan to deliver. But at that moment when we are switching the treatment on, it's an RTT who is responsible for that treatment and making sure that that treatment is delivered accurately. And I think having that knowledge and being able to do that on a linear accelerator has been fantastic to us as a profession, as a community.
So what the Ray pilot system is offering both the patient and for people who treat with SBRT is a very slick and simple process. So you know where you're targeting your radiotherapy because you can see it throughout with motion management. You can set the patient up consistently every time, so your bladder is filled with the same amount of fluid. Your rectum, we use just little suppositories to get rid of any gas. That kind of ease of setup is speeding the throughput for patients, because traditionally we've relied on men just drinking a set amount of water to fill the bladder. Well, everyone travels different distances, everyone dehydrates, everybody, makes urine at different amounts. So if you do that on a daily basis, you'll always have a different volume in the bladder, which will change the shape and position of your prostate continuously. So with that system, we have control and reproducibility before you start any treatment. Once you start treating, you then know you're hitting your target accurately. So they'd be the key messages I'd want to convey. We've understood that motion management allows you to deliver your treatment with great accuracy, but also to reduce the treatment dose to the surrounding tissues. Because it's so accurate, you don't need to allow the margins that we normally would do for movement that you can't normally see. But with the Ray pilot system, we see that movement continuously, so we know where it is. If the prostate moves out of where you want it to be, you can interrupt the beam. Stop it, let the patient settle. Is the target in the right place? Yes, switch it on. So it gives you confidence as a clinician, and as a patient it should give you confidence, because you really do want your radiation to be delivered as accurately as possible. If you're a patient, what you want is your treatment to be delivered as conveniently for you as possible. So we treat a wide population in terms of geography, so patients can travel 3.5 to 4 hours to get to the cancer centre for their treatment. So if you're doing that for many times, that's an awful burden. So a lot of men have to stay away from home and travel home at weekends. So you want to have your treatment done conveniently, and obviously SBRT brings that. It reduces the number of treatments right down to 5, and obviously if precision's accurate and successful, 3.
The toxicity that patients are reporting is certainly what everyone would describe as manageable, but what has been very, very comforting is the number of patients who are coming back after just a few weeks and they're not really reporting any toxicity, because that's obviously the gold standard that we want to get to. We don't want patients to have any form of toxicity after having this type of treatment. The patients that we are looking after are hopefully going to live for a long time, and it's not now just about let's cure these patients, it's actually about what cost or is this cure, and we really want to leave people where the quality of life is as good as it was before they started with any symptoms, or having to go to the doctor thinking that they were maybe they did have sort of prostate cancer.
It's been an interesting journey for me. It's just over 2 years now. I've just had my PSA checked again, and the good news is my PSA is now down to, I think it was 0.7. In effect, I have no cancer, no sign of cancer now, so I have to put that down to the success of the treatment. So what else can I say but thank you very much to the people that made Ray Pilot, got it out there, and thank you very much to Professor Duncan McLaren.
So I think the future is looking very exciting for men in Edinburgh to get this treatment. and in all those centres that are using the system. From a research point of view, we're really excited because we'll get some maturity of our data and the ideas about personalisation of radiotherapy. And again, if you have a system that allows you to deliver that treatment accurately, you could personalise your dose up or down very conveniently. So yeah, it's going to be an exciting few years, I think, going forwards.